The clinical presentation of Kawasaki disease can be remembered by the mnemonic crash and burn. C is for conjunctivitis. R is for rash. A is for cervical adenopathy. S is for strawberry tongue. H is for hands and feet, which is to say swelling and erythema of those parts. B is for burn, which is to say fever. The diagnosis of classical Kawasaki disease can be made clinically based on the following criteria: fever for 5 or more days and at least 4 of the 5 clinical features from the crash mnemonic. Conjunctivitis, which is typically bilateral and non-purulent. Rash, which is a polymorphic rash that can be seen on the trunk, extremities, and groin. Adenopathy, which is cervical and unilateral, with the node being at least 1.5 centimeters in diameter. Strawberry tongue, or erythema of the tongue with prominent papillae, as well as erythema of the oral mucosa and lips. Changes in the hands and feet, which may include swelling and erythema in the acute illness. Periungual desquamation occurs 2 weeks after fever onset. Patients who have less than 4 of the 5 principal clinical criteria who have fever with coronary abnormalities can have incomplete Kawasaki disease. For these patients, you can follow the American Heart Association algorithm for evaluation of suspected incomplete Kawasaki disease. If a child has a fever for greater than or equal to 5 days, with 2 or 3 of the principal clinical criteria, or if an infant has a fever for greater than or equal to 7 days without another explanation, the next step is to assess laboratory tests. C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, are markers of inflammation. If the CRP is greater than or equal to 3 milligrams per deciliter and/or the ESR is greater than or equal to 40 millimeters per hour, assess for anemia, thrombocytosis, hypoalbuminemia, elevated alanine aminotransferase, or ALT, leukocytosis, and white blood cells in the urine. If the patient has 3 or more of those findings, or has a positive echocardiogram, treatment should be initiated. In the absence of those features, the patient should be monitored clinically with repeat laboratory testing if the fever persists. A patient with Kawasaki disease is often very irritable and difficult to console. In addition to the classic signs and symptoms, they may also have involvement of the musculoskeletal, GI, GU, respiratory, nervous, and cardiovascular systems. The most concerning potential complication of Kawasaki disease is coronary artery aneurysm, which occurs in about 25% of untreated patients. With timely treatment, fewer than 5% of children with Kawasaki disease develop aneurysms. Given the wide range of potential clinical findings, a comprehensive physical exam is essential. Assess the general appearance of the child. Is he irritable? What are his vital signs? Does he appear dehydrated? Inspect the skin, including the extremities and the perineum. If a rash is present, describe it. The rash of Kawasaki disease is most commonly maculopapular, but may also be morbilliform, targetoid, or scarlatiniform. It is never vesicular. Are the hands and feet edematous? Are the palms and soles erythematous? Is there any ischemia? Complete a thorough HEENT exam. Is there conjunctival injection? Are the lips red or cracked? Is the tongue red with prominent papillae? Is the oropharynx erythematous? Is there lymphadenopathy, and if so, is it unilateral or bilateral? How big are the nodes? Are they tender? If the lymphadenopathy is diffuse, this is more suggestive of a viral illness. It is also important to perform cardiac, respiratory, and abdominal examinations, although the findings may be nonspecific for Kawasaki disease.